I'm going to share my screen and I'm going to go through the basics of VHL disease. I take that most of you are very familiar already, but please feel free to interrupt if I'm losing you somewhere and you need to ask some question. You can have them in the end, but if you think that really is unclear something that I'm saying, feel free to interrupt. I'm going to share the screen right now. I hope that you see that. Yes. Just do we see the share screen? Okay, great. So I'm going to talk about VHL disease and also belzutifan. At the bottom of the first slide is my email, oiliopoulos@mgh.harvard.edu. If you need to reach me out with some questions or with clinical problems, please feel free to do it. You can also navigate through me in order to connect with our cancer center and the VHL clinic. So if you want to be seen or you want to actually be consulted by us, please feel free to read this email or reach out to Josh. So we'll talk about the VHL-associated tumors. We're going to give a little bit of a general overview of some principles of how we detect and how we treat these tumors. I'll talk a little bit about who should be tested for VHL disease, although it's probably the area that most are very familiar with. And then the current guidelines for surveillance and treatment of the VHL disease, which lead us to belzutifan, which is the drug that has been actually changed the disease lately. So you all know that we take two genes. Every cell has two copies of a gene. One we take it from our dad, one we take it from our mom. The patients with the VHL have one of the genes mutated. That means that it has a change in the one of the base pair, so it has a big chunk of the gene that's missing out of there, and this is indicated with red here. I hope that you can see my cursor here with red. And the blue gene is the normal one. But then what happens is all the cells in the body have a blue and a red genes. That means a good one and a bad one. And then some cells lose the good one, the blue one, and this double negative cells, the cells that they're VHL negative, as we say, they start growing up and they give the tumors. VHL is also deleted in about 90% of the cases of sporadic equivalent. That means people that they don't have the germline mutation, but they develop renal cell carcinoma or pheochromocytoma or hemangioblastoma. Most of these tumors that they're not VHL disease related are starting because they are losing also the VHL tumor. So everything we learn from this tumor, sometimes we can apply to the VHL disease, and everything we know from the VHL disease, we can apply to the sporadic tumors. Not directly all the times, but many times. So let's go through the list of what are the VHL-associated tumors. Patients with VHL develop 8% of the cases hemangioblastomas. The hemangioblastomas are these benign, non-infiltrating, non-malignant tumors that they grow in the back of our head, in the cerebellum, which is the organ that's important for coordinating the movements in the body. They can move in the spine or they can move in the retina. The retina is this membrane that lines the back of our eye and through which we see. And this is because the retina, it is essentially an extension of the brain. It's a nerve cell that goes in the eye and sees the outside. So these are the areas that we're going to have hemangioblastomas. We'll talk a little bit further about it later on. At the beginning, we haven't realized that hemangioblastomas were so, often and tumors. They were so present, but it becomes actually true that now they're the most prevalent tumors in the VHL patients. 50 to 60% of the VHL patients develop renal cell carcinoma. These are malignant tumors from the beginning. 20% they develop pheochromocytomas, and again, most of them are not malignant. And when I use the word malignant, the cancer, I mean that they have the potential to spread. The hemangioblastomas do not spread. Most of the pheochromocytomas do not have the potential to spread. Renal cell cancers do have the potential to spread, and pancreatic islet cell tumors in the pancreas, which also has the potential to spread. So these are the four main players that they can give us trouble in the VHL disease. There are some other benign lesions. These are cysts or serous cystadenomas. When I say cystadenomas, I mean that there's a cyst that has some solid component inside. I like to describe it as a cyst that has grapes inside, because there are some solid round things that are like grapes, and these are called serous cystadenomas. These are developed in the pancreas. They may develop actually in the middle ear, in the area that we hear, and also contribute to the hearing and the balance. And they develop either in the epididymis, in the humans, or next in the adnexal organs, next to the uterus in women, in female patients. So let's talk about the hemangioblastomas at the beginning. Hemangioblastomas in the MRIs, they look like these very bright lesions when they give us the gadolinium. You see here in one axial, a right cerebellar hemangioblastoma. Here you see a hemangioblastoma, which is the area between the cerebellum, which is here, and the spine. We'll call that the cerebropontine angle. You see here hemangioblastomas that they are within the spine. These are the bones, the vertebra of our spine. And as I said before, they can be distributed in the cerebellum, they can be distributed in the spine. They can be distributed very rarely in the rest of the brain, the upper part of the brain. And sometimes you see that they are located in the hypothalamus, the hypophysis. This is an organ in our brain that produces a lot of hormones for growth, for reproduction, and this is kind of a sensitive area. So how do they look, the hemangioblastomas? I said they're non-malignant tumors, they're not spreading tumors. What are they? So in about 25% of the cases, you see here, they are a knot of blood vessels. They're very bloody tumors. They're essentially a sac that is saturated with blood vessels. That's why they appear also so bright in the MRIs. The typical presentation and is this one, where you see a cyst that's formed around the tumor and a nodule, the bright thing, which is the solid part of the tumor. So the typical hemangioblastoma has a cystic part and a solid part. And also we can have hemangioblastomas like this one that has a cystic part and several solid components inside. You see this kind of this cheese appearance, and very rarely they are simple cysts. So we see sometimes people that they sent by the neurosurgeons that they have a simple cyst, they have very few symptoms, and this turns out to be hemangioblastoma. I said before that the extension of the hemangioblastoma is the retina in the eye, and we see this one. And so the hemangioblastomas are also, because they're nerve cells in there, they're growing in the retina as they can grow in the brain. And the 80% of them, fortunately, are in the periphery. And when I say in the periphery, I mean in the round disc of the retina. And the retina sends all the signals by amassing all these nerve fibers into a bundle, and it's like the bundle that goes from the eye to the brain. And this bundle is here in the middle, so this bundle can develop hemangioblastomas, and this nerve bundle, and in 20% of the cases. This is a little bit problematic because the hemangioblastomas that are in the periphery, the ophthalmologist can zap them with laser treatment, and therefore, it can stop their growth. The ones that they are an optic nerve, they cannot zap them with laser treatment. And the reason is that you kill the nerves too, and then you make the patient turn blind. So there are other ways to treat these hemangioblastomas that are in the optic nerve. In the past, people were injecting anti-VEGF antibody, or they were giving systemic VEGF inhibitors. We're going to talk about this. These days, it's not the case. These days, belzutifan is almost the mandatory choice of treatment in the hemangioblastomas there in the optic nerve. So how do a patient with a hemangioblastoma compares with a patient that doesn't have VHL, what we call sporadic patients? The patient with hemangioblastoma is going to be generally younger. The earliest time that we see hemangioblastomas in a young population is 9 and 10 years old. And that's why we start screening for hemangioblastomas at this age. People that they have sporadic ones, they're going to develop first time these hemangioblastomas when they're 35 and 40 and 50 and 60 years old. The VHL patient is going to have usually several of them in many positions, and there's going to have also retinal hemangioblastomas. And the retinal hemangioblastomas, it's not that they're unheard. We did see patients with retinal hemangioblastomas that they didn't have VHL, but usually they are associated with VHL disease. How do they grow, these lesions? So these lesions don't grow, like every other tumor in the VHL patients, does not grow steadily, doesn't grow linearly. And what I'm telling you about the hemangioblastoma is also true for renal cell, pancreatic neuroendocrine tumors, any type of tumor. They alternate. They alternate between periods of time that they sleep, like hibernate in periods of time, and periods of time that they have growth. So if you can imagine over time any draw of lines, like in this case, a little bit of growth and then sleeping and hibernation, and then a little bit of growth and then hibernation, and then exponential growth, we have seen it. If you think of something that is sleeping for many years and doesn't move for 5 or 10 years and remains, 2 millimeters or half a centimeter or even 1 centimeter, yes, we have seen it. Rarely you see this very linear growth that we see here. I mean, so it's any pattern of growth, and unfortunately, neither for the hemangioblastomas nor for the renal cell carcinomas, we do have a biomarker that's going to tell us that there is going to be an impeding growth. I'll talk a little bit more about it later in the hemangioblastomas, but there is no good prediction. The only good prediction is that the last scan that tumor started becoming kind of a little bit bigger, but still it may become bigger for a while, for a few millimeters, and then go and sleeping for a long period of time. How do we treat hemangioblastomas? So we used to treat hemangioblastomas with surgery, radiation, or systemic therapy. And I put this slide and I say I used to treat historically because in my opinion, and this is not kind of a consensus guidelines, but in my opinion, the first treatment of hemangioblastoma these days is oral medication, systemic therapy by belzutifan. So we used to treat them by surgery. It was done through craniotomy, radiation therapy, or systemic therapy. I'm one of the people that does not believe very much in radiation therapy. And there are publications like from us here that they review the radiation therapy of hundreds of patients with hemangioblastomas. And the conclusion is that they are not very sensitive to radiation. It's not like when you radiate, I don't know, I mean, breast cancer or colon cancer or stomach cancer. These are not sensitive to radiation, or lymphomas. They respond better when they are very small, that they're less than 1 centimeter, and they have no cyst. Because you radiate, you actually create inflammation, and the inflammation creates growth. So they get worse, like they get bigger before they get better. And that's why people have to get steroids in order to avoid the inflammation that it is caused by the radiation. And they don't have a response like with the clinical classic criteria that we oncologists call resist, by means that they shrink. But what they do when they zap them with radiation, after they get a little bit worse, is that then they get a little bit better and they go into a hibernating site. The cyst that's around the hemangioblastomas does not respond to radiation. So what happens is that the solid component is the one that stops growing, and therefore the cyst is also stops growing, but the cyst does not regress. So I'm the least fan and the least proponent of radiating hemangioblastomas. Surgery has been the modality of treatment, and we'll talk about belzutifan in a second. So let's go to the next disease, renal cell carcinomas. As you know, VHL patients have renal cell carcinomas that they pop up in both kidneys over a long period of time, lifetime possibility to develop the renal cell carcinomas. How does a patient differ from a patient with sporadic disease? Again, VHL patients are younger patients. The renal cell carcinoma starts appearing if it's going to be appear at the age of 17, 18, 19. So at the beginning, we screen the patients for hemangioblastomas when they start to be 9 and 10 years old. But when the patients become adolescents, 17, 8 years old, even 16, we start also looking in the abdomen MRIs for renal cell carcinomas. There are multiple cysts in the kidneys. And these cysts can also have semi-solid component, like the popcorn type of including cysts, as I say, or they can be solid tumors. So the kidneys of the VHL patient can have just cysts, just solid tumors, or this popcorn bag that has cystic component and solid component. It does not mean that if there is a cyst, it's going to become solid tumor. Sometimes they fill in with solid component. Sometimes they remain cysts, even big cysts, forever. So having a cyst is not the first step of having a tumor. The tumor can develop right from the beginning without requiring the cyst to be present. Now, in comparison to the other renal cell carcinomas in non-VHL patients, the renal cell carcinomas in the VHL patients are 99% of a clear cell histology. As you probably have heard from your physicians, there are different types and flavors of renal cell carcinomas. If you put them under the microscope, the pathologist classifies them in a different way. Some pathologists talk about clear cell, other one says here is a chromophilic, oncocytoma, papillary. So there are different flavors. Essentially, these days is about 20 categories and subcategories of histologic type of renal cell cancer. VHL patients have exclusively clear cell carcinoma. The therapy of the renal cell cancer, of the renal cell carcinoma in VHL patients has actually shifted dramatically since the time that many years ago I entered the field and I got involved in the treatment of the patients. At the beginning of the 80s, what people were doing is were removing the kidney prophylactically. So you were labeled with a diagnosis of the VHL, and then what happened is your kidney was removed or both kidneys were removed, and then you were going to hemodialysis and you were suffering from all the side effects and the morbidity of the hemodialysis. Late 90s and the beginning of 2000s, people started observing the tumor because we realized then, due to the work that was done in the NIH group, that unless tumors exceed the 3 centimeters, they don't metastasize. So people started asking the question, why do you take them out? Because every time that you do an operation, besides the ribs, if you take out the tumor, you take also out some normal tissue. And by chipping away normal tissue, then you make a patient having renal insufficiency. So this is where the rule was created, the rule of 3 centimeters. We don't do anything essentially to the tumors that are less than 3 centimeters. We just watch them. And I have many VHL patients that they walk around with, 5 tumors in the right kidney and 7 tumors in the left kidney. And every time the radiologist looks at them, and now they're trained, but in the past they were freaking out. They were saying, what are you going to do with this? And I was saying, I'm not going to do anything. I'm going to watch them until they become 3 centimeters. Now, when they become 3 centimeters before the Belzutifan times, we can do partial nephrectomy laparoscopically. We can do radiofrequency ablation. We can do cryoablation that doesn't require surgery. You put a probe and either you freeze the tumor or you burn the tumor of electricity, or people who are doing small, simple enucleation, like the surgeon goes in there and pops out with a finger the tumor out of the periphery without really cutting a significant bigger part of the kidney, even if it's partial. And of course, as we're going to talk, the disease changed dramatically at 2021 because now we have an oral medication, which is an inhibitor of HIF2 alpha, which is approved for VHL disease. And this oral medication changes the algorithm of treatment of the VHL renal cell carcinomas. Let's go and kind of visit the last 2 diseases, the pancreatic neuroendocrine tumors, and I think I have the pheochromocytomas after this. So how is the pancreas of a VHL patient? The pancreas of a VHL patient may have many cysts, or may have many serous cystadenomas. I'm sorry, this is wrong in the presentation. I apologize for this. Is not papillary cystadenoma. This is serous cystadenoma. The VHL patients do not have papillary cystadenomas. They have serous cystadenomas, or they have islet cell tumors. From all these 3 types of lesions, the one that bother us, or the one that we particularly keep an eye on it, is the neuroendocrine tumors, the islet cell tumors of the pancreas, because these are the ones that they can be malignant, they can grow, and they can metastasize. We do not care about the cysts, and we do not care about the serous cystic adenomas. Despite the many cysts that we have seen, sometimes you can even see the whole pancreas is a sponge. Despite all this, I haven't seen patients developing an insufficiency in the pancreas, either insufficiency in releasing insulin and becoming diabetic, or insufficiency in being unable to release enzymes and digest their food. So despite a lot of times the dramatic appearance of the pancreas is usually working okay. So we don't do anything with the cysts, and we don't do anything with the serous cystadenomas. It's very rare that one cyst or cystadenoma grows big enough to block the biliary duct, like the gallbladder, or block something else, or give symptoms. 98, I would say, cases with a lot of cysts in the pancreas are completely asymptomatic. The other thing that I want to say is that the patients with the VHL are not at an increased risk to have pancreatic adenocarcinoma. And they are not only associated with mucinous cystadenomas. So in other words, I find almost no reason to biopsy lesions in the pancreas. People that they don't have experienced VHL, a lot of times when they see something, they're going to say, we'll biopsy it. We never biopsy any lesion in the pancreas. The radiologist can tell you if this is a cyst, if this is a serous cystadenoma, or this is a neuroendocrine tumor. And there is no reason to stick a needle in there, because if it's a VHL patient, you know what it is. Is it possible theoretically that somebody develops pancreatic adenocarcinoma? I guess yes. I haven't seen that in 25, 28 years of practicing with patients with VHL disease. They are not an increased risk. So how do we treat them? Again, before the Belzutifan, we were treating this by surgery, and we were treating by surgery only the neuroendocrine tumors. And the cutoff to operate was when these tumors were 3 centimeters in the body and the tail, or when these tumors reached 2 centimeters in the head of the pancreas. The other 2 components that they play a role in timing the intervention is how fast they grow. So if the doubling time, the volume doubles in less than 2 years, that makes us nervous, because that says that the tumor is aggressive and correlates with increased risk of metastasis. And also Dr. Tirosh published this nice paper back then when he was the NIH. He's now in Israel, that says that when you have mutations in the exon 3, remember VHL has 3 exons, 3 pieces of the gene. You have the exon 3, the third piece of the gene, you have a higher possibility to metastasize, and therefore you probably have to operate. In small neuroendocrine tumors, less than 1.2 centimeters, the metastasis is essentially non-existing. Between 1.2 and 3 centimeters, and the ones with missense mutations, the possibility of metastasis after the operation is very small, 1.2%. And when we have 3, and that's why this is the cutoff in the head, in the body, in the tail, 3 centimeters higher than 3 centimeters, the possibility of metastasis is becoming more significant, 8.6%, or of recurrence of the tumor. So this is how, again, we were treated these tumors before the belzutifan. When we check in VHL the germline mutation, people say, what does the mutation that we have can tell us? So unfortunately, it cannot tell us a lot of things. It cannot tell us that you're going to have an aggressive disease or a non-aggressive disease. It can't tell us that you know the tumors will develop early or late in life. The only thing that the mutation that we find in ourselves in VHL patients tell us is whether or not we have the risk to develop pheochromocytoma. So there is a cluster of mutations that's called type 1, and these mutations are predicted to essentially completely destroy the protein of the VHL, and these mutations do not correlate with pheochromocytoma. And there are mutations of type 2 that, you know, these are more kind of surgical point mutation, as we call them, missense, because they don't chop a big part of the gene, but they change one small letter, and these mutations do correlate with pheochromocytoma, and depending on the nature of them, they're clustered in the ones that they have low risk for kidney cancer, high risk for kidney cancer, the ones that they only give you pheochromocytoma. So your provider can actually tell whether or not you have the risk of developing pheochromocytoma and whether or not your mutation has the high risk or the low risk for renal cell carcinoma. But that's about it. It's an important information, but can't describe anything else. So how do we treat pheochromocytomas? Usually they're benign lesions. If they are not active and if they are small, and by saying small, I mean 2 centimeters, 2.5 centimeters, we observe them. If they have activity, they release catecholamines. If their size starts growing, then we tend to remove them. So to summarize it, before belzutifan, treatment of disease was renal cell carcinoma, surgical intervention when the tumor arrives at 3 centimeters, PNET, 2 centimeters in the head, 3 centimeters in the body, on the tail. Hemangioblastoma did not have a cutoff because the symptoms that somebody develops from hemangioblastoma depends on how fast they grow, where they're located, and which exactly spot in the brain. Remember, the hemangioblastomas don't metastasize. The problem is that they are inside a box, and this box is the brain, and by growing, they compete with the normal tissue, and they start pressing the brain, and this is why people develop symptoms. All right, so this is about the description of the lesions about VHL, and I would like to, I mean, this is almost like a academic exercise here, but whom do we send for testing the VHL? We have 2 clinics in Mass General. We have a VHL, and as Josh said, hereditary renal cell carcinoma center, and we have an exclusive hemangioblastoma and pheochromocytoma center that's equipped with neurosurgeons, abdominal surgeons, geneticists, medical oncologists like me, and so on and so forth. So we ask people to send us patients that they suspect that we can help. And the question is, whom do they send us? So they send us anybody who has a family history of renal cell carcinoma disease. And they send us also definitely anybody who has a family history and who appeared with one at least renal cell carcinoma. And the other thing is that they send us any patient that has two of the lesions that I mentioned before, that they're not known to have VHL, but they're suspicious of having VHL. So if a urologist see a patient that has also a history of cysts in the pancreas, it's going to be suspicious and sends the patient for VHL disease. I had once a patient refer that from a neurosurgeon many, many years ago, before we know so much about VHL disease, because the neurosurgeon operated on a single hemangioblastoma, but he also noticed that the patient had a pancreatic cyst 10 years ago. And I was young and not experienced, and I said, no, I'm sure it doesn't have a VHL disease. And I turned out that he did have VHL disease, and he made the diagnosis of VHL disease for the first time in the age of 50 years old. So anyway, so who else do we send? We refer for VHL diagnosis, testing diagnosis, anybody who has a single hemangioblastoma or a single pheochromocytoma. This is not an exaggeration, but we do this because the percentage of people in the hemangioblastomas and the pheochromocytomas that they have this cryptic VHL mutation is high, and therefore they deserve to be treated. Forget about the spontaneous pneumothorax refers to another disease and kind of interfere with the slide. So why do we want to establish a diagnosis? Of course, because then we can follow the patients, because we can prevent the development of complications, because we can treat them with VHL. The problem arises, with belzutifan, the problem arises sometimes the fact that we have a typical patient, like we have a patient who comes with 2 kidney tumors and 1 hemangioblastoma, but it's negative. She or he is negative for a VHL mutation. And the question becomes in this case, is this not a VHL? So I make my diagnosis of VHL on clinical grounds. And if I see 2 VHL-associated lesions, I call the patient VHL. 5% of the patients with VHL are mosaic. Mosaic means that not every cell in the body has the mutation. This mutation was not created when it was one cell, this individual, but it was created at the early stage of development when this individual was 8 or cells or 16 cells or 32. So 1/16 of the body or 1/32 from the body will have the cells. And it so happened that the brain or the kidneys may have the VHL mutation, develop the tumors, but the peripheral blood that we're taking to test for the disease doesn't have it. And so this is what we call mosaicism. How do we follow? What is our surveillance guidelines for people with VHL? So we start looking around the time that the individual is at risk to develop the said lesion. So when they're born, the kids are at risk of having retinal hemangioblastomas. The earliest retinal hemangioblastoma that has been actually reported, I believe it was 4 weeks old baby. It's extremely rare, but we tend, after they reach 1 year old and thereafter, to have yearly retinal examinations by the ophthalmologist. Around the age of 9 or 10, I start doing MRIs of the brain and the spine. If they're completely clean, I don't do them yearly, I do them every 2 years. But this is the area, the time that they may develop hemangioblastomas. And around the age of 15 or 16, we do an MRI of the abdomen to look for pheochromocytomas and renal cell carcinomas and neuroendocrine tumors. In type 2 patients that they may have pheochromocytomas, we also check blood metanephrines and catecholamines, and we start around the age of the toddler age, and we do them annually, or if any symptoms develop, in the kids, we do it earlier than this. But I usually restrict this to the people that they have a type 2 mutation. It is not unheard. There are some very rare exceptions, people with type 1 who have pheochromocytoma, but it's extremely rare exceptions. So how do we follow the patients with VHL? I do a yearly MRI of the abdomen, let's say an adult, of the abdomen, of the brain, the spine, and retinal examination. There are some types of concerns that they have been raised before with all these examinations, and I would like to address them. One type of concern in the past was, am I harmed by the gadolinium? Everybody knows that the magnetic resonance imaging does not have a radiation, but am I harmed with the gadolinium? And as a matter of fact, in people with reduced renal function, there was this reported syndrome of systemic fibrosis, like the gadolinium was getting into the skin, and they have this very sclerotic skin when the glomerular filtration rate was less than 30 centimeters. That used to be the case with the old linear gadolinium. Now we have cyclical, macrocyclic elements for contrast, like the dotarem, and these things essentially are non-transuddating into any third tissue. So there is not really any problem of tissue accumulation with the macrocyclic dyes. As a matter of fact, the more the time passes, artificial intelligence methods are applied to the MRIs, and the amount that they have to inject for the dyes becoming smaller and smaller. VHL and pregnancy, the second kind of big point of confusion. Does pregnancy make my VHL worse or not? So there are not definitive data. There are conflicting data. My impression, by looking the literature very carefully, and by actually having the experience with many VHL patients of mine that they became pregnant, is that is not. I haven't seen tumors mushrooming because somebody was pregnant. I think that the confusion in the literature came from the fact that women did not have a follow-up regularly in the MRIs. They became pregnant. After pregnancy, they had another MRI, and the tumor was bigger than the past. But in most of the studies, there is no good baseline immediately before pregnancy, so that we know whether or not this growth was due just to time or to the pregnancy. How about contrast in MRI and breastfeeding? There is no problem to do MRIs at all during pregnancy. We avoid to do it from at the first trimester, and particularly we avoid to inject any type of gadolinium in the first trimester. But after the first trimester, you can inject gadolinium. The tendency is not to do them during pregnancy unless, of course, you have to. After pregnancy, it is safe to breastfeed and have the MRIs. There is minimum gadolinium excreted in the milk, and minimal can be absorbed by the baby. And not to be paranoid, but to palliate everybody's feelings. I mean, you know, mothers that they want to breastfeed, they can bank blood, milk for 24 hours, then have the MRI, and then 24 hours to 48 hours later start breastfeeding again without any problem. So my message is MRI is a very benign, patient-friendly exam, and this is where we should actually put our hopes of having detection. So let's come now to the even more exciting part of the presentation, the belzutifan drug, the new oral medication that has been in the market. So what's VHL? VHL is a protein in the cell that essentially is a controller, is a policeman. In one of the presentations, I compared it with a vacuum cleaner, not to be so serious. So the vacuum cleaner that goes around and mops this protein that's called HIF, hypoxia-inducible factor. And this protein essentially doesn't exist in cells that they breathe normal oxygen and that they have VHL. So what happens is cells that they don't have VHL, they cannot control this protein HIF. This HIF protein is accumulating in the cells. It binds to another protein. This is the alpha unit, and this is called the beta unit. They bind together. This protein is not regulated by VHL. It's just floating plenty around. And so this kind of couple, now the heterodimer, as we say in the biochemical language, goes into the DNA, and it turns out a series of genes. It's about 80 or 90 or 100 genes that they turn out. And this turning out of or turning on of the genes is sufficient to make the cell become hemangioblastoma or to become renal cell carcinoma. So VHL is, as we call it, the tumor suppressor gene, and HIF is the oncogene. And if we don't have the good guy who goes around policing the bad guy, we develop cancer. So what's belzutifan doing? Belzutifan is a small molecule that the patient can take through the mouth and goes and squeezes between this alpha unit and beta unit and breaks them apart. That's because they have a small cleft there that very bright crystallographers from Southwestern discovered, that you can put a key and break apart this. And when you break them apart, none of them as a single protein can bind the DNA. So you switch off all the genes that they were turned on by the previous couple and the dimer. So here is the seminal study of which we still have a lot of data, and we study them, that establish this medication as a treatment for VHL disease. The study started at 2000, I believe, 18. It involved at the beginning 61 patients. These patients were taking 3 tablets of 40 milligram, total of 120 milligram every day at once. So you take the 3 tablets, not a tablet 3 times a day, and you take them continuously, no breaks, no stops, no anything. And the end point of this was, what was the response in renal cell carcinoma? But of course, we have also patients that they had pancreatic neuroendocrine tumors and hemangioblastomas. So going 33 years later, out of these 61 enrolled patients, there are 38 that remain in the study. 23 of these patients have discontinued the study. The study is still ongoing despite the initial publication. 11 patients discontinued because they have their own decision. It was very inconvenient to drive 3 hours to go to this cancer center and then get back, and they jumped out of the study. Also, the drug became available commercially, so patients a lot of times says, well, I'm not staying in the study and commuting to the center up and down the whole time. I can take it from my physician locally. 6 had the progression of diseases, renal cell carcinoma disease, out of the 61, it's about 10% of the cases, and that's why they were removed from the study. 2 of them could not tolerate the adverse events, and I'll talk about the side effects of the medication. There were 2 deaths, none of which was related to the medication. One of them was an overdose, accidentally, of another medication. Another one was a suicide. There was 1 pregnancy, and the drug is not compatible with pregnancy. To the patient wanted to become pregnant, therefore discontinue the medication. So this is the reason that the patients left the medication. What are the results? So let's look at the results. These are different time points that we study the results, and we jump to the latest one, which is in April 2022, about after 3 years of being in the medication. The overall response rate for renal cell carcinoma is 64%. We have a 7% complete remission, and of course the other 64 minus 462 is percent is overall response rate, is partial response. The duration of the response, the median duration, like when half of the patients still respond, has not been reached. So these responses have been continuous, and we'll talk about the side effects in a second. Here is the best picture that represents what's going on. This time is the time that we applied the medication. Prior to this is the growth rate of each single renal cell carcinoma individual lesion, and the median mean growth rate here is approximately 3.5 millimeters per year. And then after the application of the medication, you see a lot of people that they responded. These people went into complete remission. These people progressed, and therefore they were removed from the study. But the total of this group is minus 4.5 millimeter per year. So it went from plus 3 millimeter a year to minus 4 millimeter a year with the treatment of the medication. Here is the median time to response for renal cell carcinoma. It is 11 months. So the response doesn't happen very often. Patient takes the medication, then, in a scan of 6 months, they haven't responded yet, the MRI, and they're disappointed. No, the response is, first of all, the fact that the tumor didn't progress is a response. It's not a clinical response by meaning on shrinkage or disappearance, but it means that the drug does something. And then the median time to response is 11.1 months. These are people that they actually responded with complete response. If you see here, the blue is complete response. Complete response means the tumors disappear completely at 30 months, 28 months, 25 months, or 20 months. And this is the time that they had a complete response. I'm showing you this to show you the expectation. So 4% had complete response, 57% had partial response, 34% had stable disease, and 6% had disease, 6 out of 6, 10% had disease that progressed. So this is about the renal cell carcinoma. What happened to the pancreatic neuroendocrine tumors and hemangioblastomas? If you look at this column, the first, second, third from the left, people with neuroendocrine tumors were much less. They're only 22, because the criterion to involve people to enroll people in the study was to have renal cell carcinoma, and only 22 of them had neuroendocrine tumors. But based on these numbers, there is very encouraging response. 13.6% of them had a complete response. 77% have a partial response, and 2 of them had stable disease. There was no progressive disease at all. So this is partial response. 77-13 is also 90% overall response rate. This is an extremely impressive number for a tumor that is not essentially touched by any other medication, but it's a small number right now, and that's why we run bigger trials with more patients to see if that holds up. And what's happened with hemangioblastomas? Where the hemangioblastomas, there are different ways to measure only the solid component or measure the cystic and the solid component. And here I'm showing you the latest measurement that I presented in ASCO the last June, that it's solid and cystic component. And you see that the complete response is 8%. The partial response 36%, and the stable disease 46%. Only 6% progressed with hemangioblastoma. That means the hemangioblastoma became bigger. The stable disease 46%, it didn't get bigger, and we have 8% of complete responses. Now, in contrast to the renal cell carcinoma, I don't have a slide to show you the data. The responses that we see the hemangioblastoma are quite quick. We see responses within 2 months, within 6 weeks, sometimes within a month, within 3 months. It is a very early response. It is not the same response with the renal cell carcinoma. Here is a hemangioblastoma before and after treatment with just 3 months, 24 weeks. This is the difference before and after. No, that's not 3 months. I'm sorry. This is 6 months. This is 6 months, 24 weeks. This is hemangioblastoma before. This is the solid component of the hemangioblastoma in a patient of mine, and this is the cystic component, and this is after, and this is approximately 3 months. There is nothing left in the area, and this is one of my most dramatic cases. And when the patient presented, the young lady who had craniotomies before and presented with a 4-centimeter tumor in her brain and severely symptomatic at baseline. I started here on belzutifan, and 6 weeks later, the tumor shrank from 4 to 3, and 12 weeks later, the tumor was 2.5. Yes, 4, 3, and 2.5. And she's been now for about a year later, and she continues to respond belzutifan and have continuous shrinkage. Treating hemangioblastomas with belzutifan is mandatory in cases that surgical treatment is difficult. There are anterior hemangioblastomas that it's difficult to approach them. There's supratentorial, that means in the upper part of the brain, that you can do surgery. It's very complicated territory. There are brain stems that they're difficult to operate because the side effects of neurosurgery are big. Particularly these ones in the cerebropontine angle, that they start from the spine and not from the cerebellum, and the optic nerve hemangioblastomas. And in my opinion, this constitutes the standard of treatment right now. I would try first belzutifan than trying any other type of medication. Here's another example of how different became the life of VHL patients. The gray area is before treating this group of patients with belzutifan, and these are the different procedures, not tumors, procedures, the surgeries that they have: for renal cell, pancreatic, central nervous system, adrenal, retinal, epididymal cyst before, and this is how many they have after the treatment with belzutifan. So definitely the quality of life and the effectiveness of the medication has dramatically changed the life of the VHL patients. Now, how well is it tolerated? It's not badly tolerated. Almost the predictable side effect is the anemia. Anemia is not an off-target side effect, it's an on-target side effect. It's predicted because HIF turns on erythropoietin. Erythropoietin is the hormone that's used to produce red cells. So if you give a HIF inhibitor, you will suppress HIF, you will suppress erythropoietin, you will suppress red cells, and you become anemic. The real question is, so anemia is the problem. So the real other side effects are fatigue, dizziness, a little bit of nausea, headaches, muscle aches, and some biochemical type of abnormalities. The real question is, how severe is this type of side effect? Because 1 and 2 grade side effects, we have 3 and 4 grades. 4 grade is essentially death. Grade 3 is like you're required to get to the hospital and be hospitalized because of this thing. If we're looking at the grades, there are only 1 and 2 grades. They're not, they're grades that they can be, the side effects that can be addressed. 16, I mean, only, I think it's percentage, yes. Only 16% of the patients had any grade 3. And from these ones, the 10% was anemia, and the 5% was fatigue. And so this has been anemia that we'll talk in a second. We'll say it can be, addressed. So here's how overall the tumors respond. There is a period of regression of the tumors, or stability or regression of the tumors. The slope is much faster in the hemangioblastomas, much slower in the renal cell carcinomas. Then the patients go into a steady phase. This is the partial response, or if they had complete response, this would disappear. And what we have seen 3 years approximately later, we have seen in 10% of the cases resistance to belzutifan. So this is the disease progression. Belzutifan is the patient is getting worse here. Or the good news is that in some people that they have been taking the medication for 3 years, all of a sudden we see complete responses. So the tumors that they haven't disappeared for 3 years, they have been checked under control with the medication. All of a sudden, they disappear with the medication, which means that there is the biology of this drug is much different from the classic biology of the chemotherapy, even the targeted therapy, and we need to understand this is more. So what are the future clinical questions? And I think I'm going to finish in the next 1 or 2 minutes so that we can talk about questions that you may have. The clinical questions is how long we treat. We don't really know how long we need to treat. Do we need to treat forever? Do we need to treat until we get the maximum response? Do we need to treat on and off? Do we need to treat intermittently versus continuously or provide holidays? We do not know what's the optimal treatment. And we're writing clinical trials that we're actually using your support and participation to address these questions so that the next generation of the physicians knows how to use best this drug. We did see resistance. As I told you before, in the end of 3 years, we did acquire resistance. At the beginning, if you don't shrink, you just don't grow. I don't know how to call that, resistance or relative resistance. And this is, I call it de novo resistance. We don't know the mechanisms of this resistance, but we're working on it. Here's some cases that we can get back and talk about which one you're going to use or I wouldn't use or would not use belzutifan. We talked about the anemia. How do we treat the anemia? The physician can reduce the dose from 120 to 80. Instead of reducing the dose, they can give erythropoietin, or they can give a blood transfusion if the patient is critical. So if somebody is very anemic and comes in with chest pain, I would give a blood transfusion. But other than that, if we follow the hemoglobin as it goes down, and sometimes it stabilizes in a very good level, we have the time to give the patients erythropoietin. FDA does not recommend officially erythropoietin. It does not disapprove erythropoietin, but because there was a discussion about EPO in the past and whether or not it has an impact in tumors, FDA takes a neutral position. In my practice, I do use erythropoietin and more than reducing the dose of the medication. If the patient has a very good response, I may reduce the dose. The patient has just stable disease, I prefer to give erythropoietin than reducing the dose of the medication, because I don't know if there is a dose effect. I don't know if the patient with 80 milligrams will do less good than the patient with 120 milligrams. And the same extent, I don't know if the patient that gets 240 milligrams, because yes, you can take 240 milligrams, will do better and will have shrinkage of the tumors. Again, are all these clinical questions. This is what's happening with the anemia in men and women. It's the same. The hematocrit and the red hemoglobin drops at the beginning, that increases a little bit here and then stabilizes usually above 10 or around 10. And a hemoglobin of 10 or a creatinine of hematocrit of 30 is not a bad thing to have. How about, we talk about this, how about other concerns? So belzutifan is not compatible with pregnancy. The placenta depends on the HIF2 alpha. If we inhibit HIF2 alpha, the placenta shrinks, and belzutifan causes spontaneous abortion. That means that somebody decides to become pregnant cannot be on belzutifan. The other thing that belzutifan does, the market name is called Welireg, is that interferes with hormonal contraceptives. So you cannot rely on hormonal contraceptives when you take belzutifan. People, women of childbearing age, they need to use non-hormonal methods like an IUD, condoms, or whatever else. And there is a small concern, which is theoretical, about the potential effect of belzutifan in fertility. This concern was raised because, you know, in most of the times that we give chemotherapy for advanced disease. So essentially, we're trying to save life. Here, we're giving chemotherapy to not only to save the life of the patient, because this is a form of targeted therapy, but to optimize. I mean, to guarantee a quality of life for the patient. So the pregnancy, the ability to remain fertile as a young individual is very important. There was some hint of evidence that the sperm counts may go down in animal models. There is some biology that says that the eggs in women are supported by HIF. I cannot say in all honesty that I know or I have very strong evidence that it affects fertility, but out of abundance of caution and out of respect for the people that they will take the medication, they're young, and I don't want them to lose their possibility to have kids, I always advise the male patients of mine to do sperm banking and the female patients to cryopreserve eggs. And I think this is it. I'm going to stop here. I'm going to stop sharing my screen. And we can go to questions.
Dr. Iliopoulos. We have a bunch of questions in the chat. The first is, what about treating a child with an optic nerve tumor with belzutifan?
Yeah, so belzutifan has not been associated with, has not been tried in young kids yet. So it's been approved for treating adults, that means patients of 18 years old and older. There is an ongoing clinical trial that involves adolescents. So there is a possibility that's going to be approved for adolescents. It's a difficult question. I know some physicians, despite the lack of approval, have treated young people with belzutifan. In the optic nerve, the truth is that this is the only choice. This is really the only choice. If the kid is very close to becoming adolescent, and as a physician don't want to treat a 15 years old or an 18 years old, the other choice is to give bevacizumab, the Avastin antibody IV, and the bevacizumab had objective responses, did not shrunk the tumor, but it shrunk the swelling around the tumor and improved the visions, and that has been published before. So there is a possibility to bridge a mid-late adolescent to adulthood by using another VEGF inhibitor and not HIF inhibitor, either bevacizumab or sunitinib, and then when they become adults, to give it to them. If it's a 10 years old patient, or 11 years old patient, it's a very tough call. And the reason I'm saying that is that we really don't know what's the effect on belzutifan on development. It's a tough call. Let's go to the next question.
Does belzutifan affect, is it immunosuppressing?
No evidence that the belzutifan is immunosuppressant. As a matter of fact, right now we combine it with immunotherapy to see if it enhances the immunotherapy. No reason to take antibiotics, no reason to feel that you are more unprotected against the cold, the COVID, the RSV, or anything like that.
In general, does VHL affect the lungs?
Is it possible that VHL affects the lungs? I'm not aware of any data that say that VHL itself as a disease affects the lungs. There is no evidence that I know. There is no experimental models that they know. We haven't looked in doing pulmonary function studies very carefully in VHL patients, but patients don't complain of shortness of breath. We don't have any evidence for this. My answer would be no. How young is it safe to treat with belzutifan? My daughter is 11. Treatment has been anti-VEGF injections. Yes, 2 so far. Yeah, I think I addressed it before. I don't know exactly where, this question from John, I don't know exactly where the lesions are. But if the lesions are in an area that they cannot be operated, and if anti-VEGF works, I would continue with anti-VEGF. 11 is a little bit early to treat with belzutifan. And again, maybe in 5 years from now, we'll be telling you, or somebody's going to be telling you that this is fine. But right now, the concern is for development. So if I can deal with the problem with another way other than belzutifan, I would prefer those. So if it's 11 and she's treated, I assume that this is because of a hemangioblastoma or a neuroendocrine tumor, although this is kind of early, or a pheochromocytoma, or an optic nerve hemangioblastoma. And in this case, the pheo is not a problem, you remove it. The hemangioblastomas, I understand that this may be a problem, and the optic nerve, I will try to treat without belzutifan first. What size RCC tumor should be treated with belzutifan? Yes, this is a very good question. I talked to you before, and I said 3 centimeters the cutoff, but I didn't say with belzutifan. Very, very good question. When do you start? You wait for the tumors become 3 centimeters? No, I don't. I probably would start treating somebody when it's around 2 centimeters and 2 centimeters plus. If it's 2 centimeters and growing, if it's a tumor of 1 centimeter and 1.5, I would not start on belzutifan. I would try to start the medication as late as possible. Why? Well, first of all, because it has the side effects of anemia, then because the person should go continuously for having blood checks. I would check blood at the beginning once every 2 weeks and later every month. So it is a hazard. It's a complication. In the best scenario, it's a slight complication in the everyday schedule of life to be treated with a medication. So what I would say is that I would try to kick the can down the road as much as I can. If the tumors is 2.2, and I would do another MRI and see if they grow in 3 months. If they're active tumors that they're growing past the 2 centimeters and they're away to the 3, I will start treating. If I treat, I skipped one of the slides, but the question again is going to be if I treat. So if it is one single tumor in a kidney, I wouldn't treat it with belzutifan. I would send to the surgeon. If it is several tumors, or it's a tumor with somebody who has a creatinine of 2.5 and one more operation would push this person over the edge to hemodialysis, I'll treat it with belzutifan. For the hemangioblastomas, I consider belzutifan first line of therapy. For the renal cell carcinomas, the fork decision is surgery or medical treatment, and that will depend on the age and the condition of the patient. If there is a woman who is 26 years old and doesn't have kids and wants to have kids and has 1, 2.5, or 2.9 centimeter lesion in the kidney, I won't treat with belzutifan. I would send it to the surgeon, takes it out, and we're done, instead of going through IVF and cryopreserved eggs. If it's somebody who is 45 years old, she's done with kids, she doesn't have any interest, I will be much more prone to treat with belzutifan. And again, in any age, if somebody who has 3/4 of the kidney left, I would have a very low threshold to put on belzutifan, so that, because I know they cannot tolerate one more operation. But it's a good question, the timing of treatment. And the same goes for hemangioblastomas. When do I treat? I would like to treat not when they're symptomatic, although I have been very cavalier and I treated people when they were moderate symptomatic, almost severe symptomatic for hemangioblastomas. I think colleagues of mine would criticize me for this, but the person had 2 craniotomies and the patient said, I don't want to go for a third one. And I gave this patient belzutifan, and was one of these people that miraculously within 6 weeks, the tumor shrunk and the patient became asymptomatic within 2 weeks because of the anti-edema effect of belzutifan. But I would like to treat patients before they become symptomatic. So if somebody has stable hemangioblastoma lesions over time, I would not treat. If somebody has growing hemangioblastoma lesions and the growth is steady and continuous, then over a period of 6 months, 9 months, and I'm getting nervous that this tumor will start to create problems, then I will treat. Or if the tumor starts developing a cyst, then I will treat again because the cyst is not being treated by any other modality than by surgery. By the way, administration of belzutifan shrinks both the solid component and the cystic component, in contrast to radiation. Radiation only affects the solid component. When you give belzutifan, you see a parallel reduction in the solid and the cystic component of the tumor. Next question is, what are we learning about classes of drugs or specific drugs that may work well in combination with belzutifan? We don't know anything yet. We try now immunotherapy in combination with belzutifan, but many people work in the lab experimentally to find out the resistance and find out actually how we can combine belzutifan with other medications. So this is a very early question. People are working on testing this combination. For the time being, we don't have a establish other medication that we know that it enhances the role of belzutifan. What time do we imagine that they will be able to complete phase 3 with a greater number of patients? Well, I don't think that they're going to complete a phase 3. I don't think we need a phase 3. I think that instead of phase 3, we need the clinical studies that I mentioned before, like continuous versus intermittent, increased dose versus lower dose. I think this is the right clinical studies. I don't think we need a phase 3. I mean, it's the drug is working so clearly, we don't need phase 3. Now, it's a possibility that the European regulatory agency demands phase 3. So we try to increase the number of the patients from phase 2. And we try not to do a phase 3, but there is a possibility that we do a phase 3 because of regulatory requirements, which I believe it would be a travesty. I mean, it would be a really bad idea, because phase 3 means that we're going to treat the patient with belzutifan versus placebo. I wouldn't like to take placebo if I was a VHL patient. The impact is so clear with 10% complete responses and 50% almost partial responses, another 40% disease stability, which phase 3 is just a bureaucratic actually way. And I say that with a intensity because I think that the European Union is wasting time. Lesion is next to optic nerve. I see. You're responding, John responds before regarding his 11-year-old daughter. If VEGF works, bevacizumab, is it? I don't know if it's VEGF injection. VEGF injections don't work very well, but they may work a little bit. Systemic administration through the vein of Avastin may work in this case. The other possibility, if it's not exactly in the optic nerve, but it's next to the optic nerve, is there is a possibility, if you find a very skilled ophthalmologist, to do surgery, not laser treatment, but actually surgery for controlling this type of lesion, or to potentially do some very local radiation. It's a very, very sensitive area. It's a very sensitive area. The best thing, you can contact me and we can talk about it. I mean, there's some ophthalmologists that they become a little bit innovative. Please send me an email. We'll be in touch. I can help you with this. But if I say, well, I would bet right now my money would be to do systemic treatment with bevacizumab, Avastin, and see if that can hold for a while. Is the response to the drug dose related, or is it unpredictable? Yeah, we don't know what's the effect with the dose, because everybody started at 120 and we still have people at 120. For reasons of anemia, I had to reduce some people's treatment to 80, and still it worked. So I don't know if the 120 is required. Speaking on the other side of the coin here, is it possible that a patient that did not have a great response with 120 would have one if we go to 180 or to 240? I don't know. Is it possible to go to 180? Yes, it's possible. Preliminary data for some studies shown that it's possible to go to 180, and the drug is tolerated. So we are not yet very comfortable that we exploited the dosing effect of the drug in either direction very, very precisely, and that's why we need to do a clinical study. Beyond standard lab values, are there symptoms those of us who are on belzutifan should watch out for that may not be as easy to see as fatigue or GI issues? No. I think that if there are any symptoms that you you experience, you should report them. Fatigue may be related to anemia, may not be related to anemia, maybe from the drug, maybe a bit of nausea, maybe from vomiting. One of the side effects that has been reported is low oxygen when we measure them, the peripheral blood. This low oxygen, I think, is not a usual side effect, and it is completely asymptomatic. People do not respond that they sense this hypoxia. They don't say we're short of breath. And we as physicians are a little bit nervous and leery about it because we say, well, they become hypoxic. They don't know they're not short of breath. What does that mean? I'm not sure what that does mean, and I'm not sure that this is particularly problematic. I'm usually concerned about people that they have COPD, chronic obstructive pulmonary disease, because they were smoking, or people that they have sleep apnea. In these two conditions, the rate of breathing depends on oxygen. So if you blunt the response to hypoxia, you may prolong a little bit the apneic phase. But this is something that we need to study more. I don't think that anything else other than that you should be overwatching and been leery about. Would you still recommend belzutifan? It's moving for patients with hemangioblastomas, the central nervous system, even though the patient was previously treated by the gamma knife procedure? Well, I wouldn't recommend it unless the gamma knife procedure failed and the patient's tumor grow. Again, I would not treat some tumor because it's there. I would treat this tumor because it grows. So if the gamma knife put the tumor as the hibernation, I don't see any reason to treat. If the gamma knife, after a period of time, fails and the tumor starts growing, then I would treat it as any growing tumor. And yes, I would not hesitate to give belzutifan. Is belzutifan the same as Welireg? Yes, it's the same drug. Welireg is the commercial, and I'm sorry. What do you think of contrast-enhanced ultrasound to treating RCC? The contrast-enhanced ultrasound, they are not treating the RCC, they diagnosing the RCC. There are, to the best of my knowledge, there are more sensitive and more quantitative methods to measure renal cell carcinoma without doing CAT scan of MRI. I'm not aware of treating the renal cell carcinoma with with enhanced ultrasound. Is the belzutifan the same as Welireg? Yes, sorry about this. How closely do patients on belzutifan need to be monitored for anemia and hypoxia? How often do they get labs? Well, when I start treating with belzutifan, I tell you what my algorithm is. So I start treating with belzutifan. I don't know how the patient is going to do with regards to anemia, so I do labs every 2 weeks for 3 months. By the end of 3 months, I know what the profile has been, how long the creat is going to drop, how fast it's going to drop, when it's going to come back again. By 3 months, I have a good understanding if this patient is going to require EPO or not. So then I switch to monthly labs. And of course, you always go clinically. I do monthly labs and the hemoglobin is 10. And then I say, okay, let's have one lab draw next month in 30 days. If in 20 days the patient says, you know what, I feel very fatigued, I'm not going to say, oh, no, let's wait 10 more days to do your lab. Well, we'll do the lab then. I mean, if it's triggered by a clinical need. But once a month, it's good. And I think I consider I follow the beginning. The big changes happen at the beginning, and then you have stabilization. Now, when you stabilize, you may be stable for a long time, or they may be the hematocrit, the hemoglobin may start decreasing gradually. Well, you will see this. Your physician will see this over the next 2 or 3 months. So there are patients that I have that require erythropoietin every 3 months, 1 injection, or every 2 months. But once a month after the first 3 months is good, and every 2 weeks during the first 3 months. There are some other questions just helped that I think that I missed. Oh, I meant diagnose RCC with contrast enhanced MRI, ultrasound. Yes, I think it's a very good tool to diagnose RCC. I do not know how does it compare with MRI. It is a new method. It's definitely a easier method for the patient instead of shoveled in these tubes of the CAT scan. I don't do CAT scans or the MRI. And I think that probably gives you accurately the size of the tumor. I don't really have any reason to believe it's going to be more sensitive than the MRI, and I doubt this. It's definitely more convenient than the MRI. So it's not going to be an unreasonable strategy to do contrast enhanced ultrasound to see if there are any tumors, and if there is some tumors, or there is some growing tumors, to revert to the MRI to have more accurate measurements. When you talk about response in CNS hemangioblastomas, is that measured as greatest diameter of a target tumor or using a volumetric measurement? Also, do you see different responses with a single patient based on hemangioblastoma size? Right, so both. So the greatest diameter and the volumetric measurements. I have a series of 30 patients in Mass General. We hope to publish them actually soon, that we treat them with hemangioblastoma. Even if you go by the diameter, if you go by the volume, it's the same thing. I mean, you know, these are spherical, or actually, they're not spherical, they're elliptoid lesions, many of them. So both the response. I like to do volumetric responses. And I like to do volumetric responses because the size, the space occupying size is the sensitive component in the brain, because the space is restricted. And also because it's more dramatic. You see higher percentage reduction by doing volumetric. The numbers look more dramatic, so it's more satisfying for the patient and for me. I say that with a sense of humor, but it is. I mean, the volume really goes down a lot. And do I see differential responses within a single patient based on the hemangioblastoma size? Yes, not all the hemangioblastomas shrink the same. I have a tendency to say, and I'm not sure for this one, we need to finish the study of these 30 patients. I have the impression that the smaller lesions get a bigger response. But again, the smaller lesions is much more difficult to measure them accurately. If you have a 3 millimeter, 4 millimeter hemangioblastoma, something would not be an evaluable lesion by the classic RECIST criteria. If these 4 become 2 or 1, it's a very dramatic response, but it's also much less accurate in measurement. I'm not sure. I'm not sure if the small ones, I have the bias or the very non-substantiated impression that the small respond better than the big, but I also very big hemangioblastomas as the patient that I show you, that they responded a lot. Thank you, you're very welcome. Oh, there's a long one. That's a short one. What's the best way to know if the drug is working or having a positive effect? Imaging. Your symptoms are going to be better, and then the kidneys, imaging. Do MRI of the kidneys of the target lesion and see if it shrinks. That's the effect. And I'll take this last one. It's a long one, but I'll read it. Both of my kids have open partial nephrectomy surgery on opposite kidneys last fall, and it appears that my husband will be up next with a tumor while watching that's just under 3 centimeters. We got the disappointing news last week that my son is developing a new mass in his other kidney. The surgery was successful, however, I didn't know if other surgeons are having success with less invasive methods. Would be some doctor you addressed. You can contact me in the email, and we can talk about this offline. One of the questions that I would ask is why your husband, your kids are not treated with belzutifan, because I assume they're adults, and instead of operating continuously, why shouldn't we treat them with belzutifan? Is there any contraindication? Hard to believe there is any contraindication. So I would essentially consider, instead of doing continuously surgeries, to treat them with belzutifan. Feel free, that came from VHL Alliance. So Josh, feel free to direct this person who asked the question to me through an email, and we can talk about it. I think that I can get this person to belzutifan. Anyway, I'll stop here. I thank you very much for joining us tonight. I hope that this has been helpful. And again, we're going to learn a lot over the next years from this medication, the combination with other treatments. Please stay involved with the VHL Alliance, attend our meetings, support the Alliance, that we try to raise funds to support research. And again, once again, if you have any questions, I'm very happy to answer them in my personal email. Good night, everyone.
Thank you, Dr. Iliopoulos, and thank you everybody for joining us. Good night.
Bye, Josh. See you soon.